Hi, everybody. Welcome back. Sorry for all the technical difficulties we had this morning. I'm hoping that everything's fixed, that we can go back to this room and present from this room. Our next topic is our trauma-informed care and what we do here, caring for people with who are using drugs. And we have Keenan Ross to talk to us about it. Keenan is the clinical nurse leader for our urban health program. Prior to that, there is a Slido question. So if you guys could go to slido.com, #GoPHC to answer Keenan's question. Thank you.
We have like 40 people.
Okay.
Yeah. You might get 10 responses.
What?
You might get 10 responses.
One is good. One response is good. These are all good answers. Anybody else? Last call for answers. Yes. That's a wonderful answer. The behavior towards treatment. Yeah. Oh my gosh, these are all such great answers. It's so great to see that people are considering their own bias and what they might be carrying with them. Tolerance to opioids is a huge challenge these days. Overdose is also a challenge. Yeah. Okay. So good. I'm also just going to, sorry, my brain is not fully working. So just as a quick, I think you guys probably already did a land acknowledgement today, but it's just important, I think, that we really acknowledge that we are on unceded and traditional territories of the Squamish, Musqueam, and Tsleil-Waututh peoples. And part of this acknowledgement that I think we really need to pay attention to in healthcare is that we are working in a colonial infrastructure, that healthcare itself is a colonial tool that was used and is still used to control our Indigenous populations. So it's always something we need to consider when we're providing care. Okay, now I go to here. Oh, I did it all by myself. I think that's the first time. All right, so as was previously mentioned, my name is Keenan Ross, and I am the clinical nurse leader on the urban health program, in the urban health program here at St. Paul's on the inpatient unit 8 Alpha. So we're going to talk a little bit about, we're going to talk a lot about actually addiction and trauma-informed practice and how we can change our approach to providing care for people who are actively using drugs. Because they are traditionally seen as a very difficult population to serve. And really, there's a few small things that if we employ these tactics, things get a lot easier and our patients are able to actually participate in care and be present for their treatments in hospital. So sorry. Gabor Mate, who wrote In the Realm of Hungry Ghosts, who practiced here on our palliative unit and who also worked extensively in the downtown east side, talks about addiction as a relapsing behavior, satisfies a short-term craving and persists despite long-term consequences. So that is in spite of losing children, going to jail, not having jobs, all of those sort of big name consequences. It's a very complex condition. Some people consider it a brain disease, and it's usually manifested by compulsive substance use, despite consequences, as we said. And there is usually a very intense focus on using a certain substance. A lot of the people that we serve at St. Paul's are using fentanyl, and a lot of people are using stimulants such as crystal meth or crack cocaine. So they will keep using drugs and alcohol when they're in hospital, and it's actually not realistic for us to expect people to abstain. This is a coping mechanism for a lot of people. So they'll keep using even though they know it causes problems. And there are treatments available, but it's the process of getting people into those treatments and all the barriers around it that often make it impossible for people to do that. But people can recover from addiction and lead very, very what's considered normal and productive life. So we have to think about how does addiction progress and what does it look like? If somebody has like a CVA, they have a stroke, we can put them in a CT scanner, we can see their brain, we can see everything that's going on, we can see it progressing, and we're able to sort of track where they're at with the pathology of that condition. With addiction, it's a little bit different because the functions that typically start to be affected are emotional life, relationships, thought processes, decision-making, and behavior. So a lot of that stuff happens inside a person's head, and we see the outcome of it, but we don't often see how they get there. And so part of the other thing with addiction is that it does change the actual reactions in the brain, right? The neurotransmitters are all reacting to whatever drug is being consumed, and it can result in some pretty significant changes to brain chemistry, some of which can be permanent. And so basically the more a person uses and the more that their brain is changed, the greater obstacle they have to overcome to get back to optimal brain function. So there are a lot of people that get addicted to drugs, and it's all different reasons. There's trauma, which is a huge, huge factor. Pain, chronic pain, acute pain. There's mental health, and there's also genetics. Genetics, I think, plays a way lesser role than we thought initially, but certainly mental health, pain, and trauma are big, big factors in substance use. So trauma is it's sort of a buzzword these days. You know, you hear a lot of people talking about it, and it can mean a lot of different things to a lot of different people. But in the context of this presentation, we're talking about an experience that overwhelmed an individual's capacity to cope. So it can be trauma in early life. So it can be child abuse, neglect, witnessing violence. We're now starting to see a lot more information around disrupted attachment between children and parents. And then there's also stuff that happens later in life: violence, car accidents, natural disasters, wars, sudden expected loss and complex grief, global pandemics, all sorts of other things that can affect people throughout their lifespan. And you know, what is trauma to me might not be trauma to somebody else, and vice versa. But if it's devastating to me, it can have a really huge impact, not just on my physiology, but on my emotional health, my mental health, and my ability to cope. There's a lot of types of trauma. There's like a single incident trauma, complex or repetitive trauma, developmental trauma, intergenerational trauma, and historical trauma, which we're seeing a lot of in our Indigenous populations right now. And then there's primary trauma versus secondary trauma. So primary trauma is something that would happen to me, and secondary trauma is something that I witnessed. So I find these sort of comparisons to be really helpful when we look at what trauma causes and what drug use causes or produces. It becomes very easy to see why people are using drugs to deal with their trauma symptoms. So depression and anxiety, anger management issues, compulsive and obsessive behaviors, dissociation is very common, being very overwhelmed with memories of trauma, lots of nightmares. There's a lot of difficulty concentrating and feeling distracted by intrusive thoughts. Fearfulness, emotionally numb and flat presentations. A lot of people lose time and have memory issues. And then there's always suicidal thoughts, sometimes homicidal thoughts. And then when we look at drug use, people report feeling euphoric, they get calm or relaxed. There's a sense of escape. There's a feeling of being free and safe and included. There's a camaraderie amongst people who use drugs. There's an ability to focus and complete tasks for a lot of people who have like ADHD or things, situations like that. And then there's this notion of sort of being like strong or unstoppable. And I think that that really sort of speaks to, you know, that helplessness and fearfulness that people feel in trauma. When they feel strong and happy, things get easier. And there's also that sort of like giddiness and lighthearted enjoyment, like nothing is so serious and, you know, everything's going to be okay. I mean, our systems in themselves cause a lot of trauma, particularly to people who use drugs, which is really ironic when you consider that people are using drugs because of trauma. So the more pain that you cause people, the more you shame and isolate them, the worse they're going to feel about themselves, the more suffering you impose, the more you strengthen their need to escape. If you wanted to design a system to maintain drug use and enhance the profits of the illegal drug trade, I would design the system you have. And this is another quote from Gabor Mate talking about the war on drugs and just basically how historically we have created the situation that we're currently in with people using drugs as far as criminalization and ostracizing people. There's a lot to it. So if we're effectively going to care for people who use drugs, we have to look at trauma-informed practice. And these are just 4 sort of basic points that we can look at, and I'll sort of enhance them a little bit. And I apologize that this is really nursing focused. I recognize that there probably are other disciplines watching this, but just sort of think about how it could apply to your role in patient care, because I think the more aware the whole team is of the need for these steps, the easier it gets to have sort of like a conducive team approach. So the 4 principles we'll look at are trauma awareness, emphasis on safety and trustworthiness. So how do we build trust? Opportunity for choice, collaboration, and connection, and then strengths-based and skill building. So the very first thing that we need to understand is what a trauma reaction can look like. What is somebody who is experiencing trauma? How do they present? And sometimes none of these things happen, but these are just sort of standard trauma presentations. So there can be sweating, a change in breathing. Some people hold their breath or they breathe really quickly. Rigidity and muscle stiffness. There's difficulty relaxing. Floods of strong emotions. We see this a lot in patients where they'll just have a huge outburst of anger, and maybe they're screaming and yelling, or maybe they're super sad and weepy and sort of hopeless. Rapid heart rates, a startle response, and flinching. The startle response is actually a big one that we see, and I like to remind every person that when you're going into somebody's room in the morning and they're sound asleep, you go in and like throw on the lights and start talking really loudly, it's actually really disturbing to a lot of people. So be conscious of the fact that people might be startled out of their sleep and they don't always react very well in those scenarios. Some people literally shake. There's this staring off into the distance, which is sort of like that dissociation thing where physically they're with you, but they are not connecting to anything that you're saying. And then becoming disconnected from a present conversation and losing focus. So sometimes you'll be talking to somebody and they're paying attention and everything's going really well, and then you'll notice that they're just not with you anymore. And sometimes that's their inability to stay present in a difficult conversation. And that can be avoided by, keeping things as short and simple as possible. And then there's the inability to concentrate or respond to instructions and the inability to speak. So some people just shut completely down. And they're literally not there. Like their body is in a place where their fight or flight system has kicked in and they're not capable of being present. So emphasis on safety and trustworthiness. This is probably the most important piece that I have found in caring for people who are using drugs. Nobody's going to stay in an environment that they don't feel safe, and nobody's going to work with a healthcare provider that they don't feel that they can trust. So hospital environments are often sites of trauma. They're often sites of, the unknown and anticipation and pain and fear. And it can just really cause people to just either, shut down completely or they just leave because they don't trust us. They don't trust our intentions. They don't trust the situation. So remembering that people come to us with a whole host of life experiences, and that's really going to shape how they feel, what they think, and how they respond to us. And that's a huge piece of learning to engage people in care. You know, maybe they lost a family member in this hospital. Maybe they, you know, were hurt or abandoned in a hospital. And I mean, really, when you look at all of the stuff that's been going on with residential schools lately, St. Paul's Hospital looks exactly like a residential school. It's a big red building with a whole bunch of religious statues and a religious name. And I know that even the site of the building can be too much for some folks. So it's really important that we listen to them and catch, you know, sort of those little things that they drop about feeling safe. And whether that's being, you know, some people just need to be in a private room. And I recognize that some don't consider that medically indicated, but if somebody tells you straight up that they can't sleep in a 4-bed room, and we know sleep is a huge part of healing and recovery, then it is medically indicated. It's time for us as healthcare providers to acknowledge these things, not as, you know, like a huge demand, but they're telling us exactly what they need to receive care. So there's always going to be hungry, angry, lonely, tired. These are things that are gateways to being able to comfort and support people. A lot of our patients are super hungry. We have snacks. We, you know, we'll make sure that meal trays are ordered. We'll make sure that there's extra cookies around, things like that. In particularly difficult situations, sometimes we will, you know, go as far as grabbing, like getting money together and ordering pizza for somebody or things like that. Like, you're not obligated to do these things, but these are just little tricks that have worked for us. I know when we had a COVID outbreak on our unit last year, at the end of it, we bought Big Macs for everybody because they'd all just been under so much pressure with the repeated swabbing and all the restrictions, and everybody just needed to laugh a little bit. So we went and ordered a whole bunch of Big Macs and, you know, like pushed this cart down the hallway. It was really, really fun. People get really lonely. As I was saying before, there's a lot of camaraderie amongst people who use drugs. You know, there's a lot of street family ties and things like that. And being isolated and alone in the hospital can be really difficult. So we try to encourage people to have their visitors when we're allowed and when it's permitted. And then the fatigue factor is huge. A lot of the time, if people are living rough or they're living on the streets, they are not sleeping. So, you know, they'll come in and they'll crash for a couple of days, and it's really difficult to get anything done in those first couple of days if they're that tired. But I find that if we give people space to sort of have a good sleep, then they're a lot more amenable to being engaged in their care the next day. And this idea that that's a waste of time needs to go out the door, because again, rest and nutrition are huge pieces of health. Some people have a lot of stuff going on outside the hospital. So they might have pets at home, or they might have, you know, they might have a job that happens here and there. And it's important that we remember that people have things they need to do. And if we sort of understand what those things are, we can tailor our care around it. Okay, barriers, perceived or visible. So things like patients who are homeless, who are carrying all of their belongings in a shopping cart, or patients who, again, have a pet at home, or patients who just cannot handle sitting through emergency. You know, sometimes we have to arrange for direct admissions with our community partners because people can't handle going to the emergency room. And that's something that I hear a lot from our Indigenous patients. They will not go to emerge. It's too traumatizing, and they've had terrible experiences there before. Transparency. I think it's really important that we are consistent and predictable to our patients. So, you know, if you show up one day and you're having a conversation about the rules, then it's really important that we hold those rules. So this is boundaries is the next one. So we need to set boundaries for our patients, and we need to respect the boundaries that they set for us. So I think one of the things is, you know, some people don't like being checked on overnight. So we come to agreements about how we can do that without disturbing their sleep. Or, you know, they say to me, I don't want to have a male caregiver if they're a female patient. And, we do our best to sort of support those requests. We gender cohort on our unit, and that's a huge piece of making our environment safe. Schedules are important, and consent is needed every time for every task. So just because somebody said yes to you yesterday doesn't mean that they are still saying yes to you today. And then the expectation piece between nurses, I think, is actually where it gets a bit messy, and between all caregivers, in fact. If we're going to set rules and boundaries for people, then they have to be consistent. So, we have a rule on our unit that we don't give out snacks after midnight. So a nurse sneaking a snack to somebody at 2 a.m. actually doesn't do anything to bolster trust or safety. So sometimes when we think we're doing something good, we're not. And collaboration. So understanding what the patient defines as safe and what we define as safe, right? Like, we think of the hospital as a fairly safe place, and we think of our colleagues as safe people, but that's not always the case. And it's important that if we notice that patients are, sort of uncomfortable with a situation or a person, that we address that and we tell them that, they're allowed to tell us what they need. So opportunity for choice, collaboration, and connection. This is a huge one. And I catch a lot of slack from a lot of people in the hospital for not forcing patients to go for diagnostics, or, demanding to know where they are on the OR slate so that we can tailor their NPO orders in properly. If somebody doesn't want to go for a CT scan today, that's fine. They can go tomorrow, and I think that if a person is really resistant to something, it's important that we tell them that, it's okay to make your needs known. It's okay for you to say no to us. We'll still care for you anyway. But then we can also put the responsibility back to them. You tell me when you want to do this, and then you need to follow through on that. Schedules, timing of medications, routes of medications, wound care, etc. So there's somebody sitting in a provincial pharmacy office somewhere that decided that methadone should be given at 8 a.m. And that's actually the reason why it's a standardized time, because there's no actual reason for it. And we need to consider that a lot of our patients go for daily dispensed medications. So if they're going to the pharmacy at 5 p.m. And we're waking them up at 8 a.m., it's not actually written in stone that methadone has to be given at 8 a.m. So we can talk to people and say, hey, do you want to take this in the morning? Do you want to take this in the afternoon? Provided we do it within the policy, which is, doses are 3 hours apart. It's fine. There's always ways to explain why medication timing is changed. Obviously, for things like antibiotics, which we try to keep on a schedule, we do our best to do that. And we do our best to make sure our patients understand why we're doing that. And that's important stuff, because the more people know about these things, the easier it is for them to participate in their care. I also always make sure that my ambulatory patients have a piece of paper that has their antibiotic schedule on it. And I think that that's a really great way to empower people to get there and be there for their medication. Having a sense of personal control and interactions with practitioners who have more power than them is crucial to engagement and establishing and maintaining safety. We have power. We have power in the sense that we're in the uniform, we have the medications, we can discharge people, we can admit people, and it's so important for us to remember that, because I know, when I was a new grad nurse, I felt anything but powerful. But you still hold power, even if you don't think you do. And I think that this is something that we really need to work on. And, some practitioners are better than others at the bedside, and it's important that we sort of help each other to safely support patients. So if you see something that's not right, you can quietly address it. A lot of this is language is really important. There's this whole thing around addressing people as addicts, which is highly problematic, or, urine tests as clean or dirty, which is also highly problematic. So it's important that we sort of get on the same page as that. get on the same page as practitioners so that we're, you know, really acknowledging the power of our actions and our words. Principle 4 is strengths-based and skill building. So honoring autonomy, you know, people are allowed to make their own decisions. We don't have to like them. We don't have to think they're the right decisions, but people get to make their own decisions and they have the right to live at risk. So a lot of the times people can get very, you know, emotionally and ethically challenged over some of the things that we see. And we just have to remember that our job is to support our patient to make a decision, not which direction they're going to make the decision in or what they're going to do, right? We just need to make sure that they feel safe enough that they can tell us what they're going to do. And the other piece of it is some people are really good at, you know, organizing themselves, and we need to really embrace that. We need to really make sure that people understand, you know, if you say like, oh, okay, we're going to do an MRI of your, you know, your left hip and this and that. And they're like, why? Like, they don't understand that that could be affecting their bacteria in their blood or things like that. This is another piece that comes in. We've run into situations where patients are using their lines to use drugs. And I mean, people are going to use drugs whether we give them a line or not. And they're probably going to use the line whether we say yes or no. So it's also like acknowledging that, you know, people are going to do what they're going to do, and there are safe ways to do things, safer ways to do things. So using a lot of harm reduction approaches in those situations. And the one last thing that I want to say about, sorry, I should have said this on this opportunity for choice, collaboration, and connection is, you know, one of the things that I've noticed is the way that we approach patients' bedsides. And sometimes we go in there and we're all standing around the bed and we're talking down to the person, and that can be really, really intimidating. So just, you know, be cognizant of your body language and your positioning when you're talking to people. All right, so what does this all mean? It's all very scary at first, and nobody expects anybody to understand this completely. And it's something that gets easier with experience, and it's something that gets easier as you learn more about people who use drugs. And people who use drugs are the best people to learn from. So we need to really look at why we think the way we do about people who use drugs, and really look at that internalized stigma and, you know, what the media has always told us, and how does the war on drugs inform our current situation? How does it inform our practice, right? Do we automatically assume that people are going to lie, or they're going to be late, or they're not going to want to do something? And how does it affect how we care plan? It's significant. And when you start to look at those things that you're assuming about people, these internalized stigmas and bias become very clear. Okay, fentanyl and opioid dosing. I know that somebody had said in the first part that they were worried about overdose, and then somebody else said treating pain. And you know what? It's really touch and go right now. The fentanyl poisoning epidemic has made our jobs very, very difficult. And one of the things that is important to remember is that fentanyl is very hard and short acting. So people get a huge bang and then they're sick right after. Opioid dosing. So people have extreme tolerance right now. And, you know, we're giving IV fentanyl, we've got patches, we're giving infusions, we're doing all of these things, and people are still showing signs of withdrawal. So it goes beyond just meeting those physical needs at this point, and we actually have to do a lot of sort of, you know, pep talking with people and talking them through really difficult situations. But it's also important that we make sure that our patients are being dosed correctly. You know, if somebody comes into emergency and they report using a gram of fentanyl every day, and they're given 1 milligram of hydromorphone PO Q4H, they're gonna leave. Because number one, that's not going to support their opioid needs as far as keeping them from going into withdrawal. And it's also not going to deal with their pain. Pain and withdrawal are two totally different things and need to be assessed as such. So knowing sort of the onset and the duration of different medications and different routes is something that I recommend that newer nurses pay very close attention to. And, you know, don't be afraid to say to a doctor, I've noticed that this person doesn't have any opiate replacement therapy and their history has a significant substance use disorder. It's our job to advocate for our patients, right? And I think that that is one of the biggest pieces that gets missed. The sedation piece is also really interesting right now because some people literally just want to be obtunded and are not happy until they're obtunded. And that's really scary for us. But the way that we sort of do it on our unit is, you know, we'll throw a SAT monitor on somebody, and if their rest rate is 9, but their O2 SAT is 100, and they're comfortable and they're sleeping, we're not going to do anything. We're going to leave that monitor on their finger and we're going to watch them. The risk, of course, I don't ever want anybody to be afraid to Narcan somebody, ever, but just keep in mind when you do that, that reverses all of the opioids that they've got in their system. They're going to wake up extremely withdrawn, and they're going to probably swing really far the other way, overdo it, and overdose again. So it's about doing sort of small things. You know, we'll give a tiny little bit of Narcan and see if somebody perks up and they wake up, then we leave them, right? We're taught in school that an overdose is, you know, it is an emergency. I don't want to say it's not an emergency, but we have all the tools in the world to deal with overdoses. Narcan is very effective. You know, we've got oxygen in the walls here. So if people's oxygen goes down, we can put oxygen on them. We can call it code blue and a whole bunch of people will come running. It's also a really important thing that we're encouraging our patients not to use drugs alone. And that includes at their bedside with the curtain closed. There's this sort of idea that urban health is like the Wild West and we let everybody do whatever they want, and it's not true. People are not allowed to use at their bedsides. So if you hear somebody say that, you tell them it's not true. We do not allow people to use at their bedsides. And we do have an overdose prevention site at the hospital now inside. It's staffed with nurses, and it's available for all inpatients to use. Okay, so how does this all inform our practice? Well, basically it means that, you know, we're all learning, things are rapidly changing, and the best thing to do if you're in a situation with a patient that you're not sure about is to get another colleague to help you or to ask the patient. You know, if I say to somebody, hey, are you in pain or are you in withdrawal? They'll be able to tell me I'm in withdrawal. And a lot of our patients are very, very wise about their dosing and what they need. And the idea that people are med seeking is stupid, because if they really wanted to get medications, they could just go get carries of hydromorphone in the community and self-medicate on their own, right? They don't actually need our drugs. And that's something that we need to remember. All right, so these are just some little like examples that I've put together based on some situations we have seen in our unit. And again, nobody expects anybody to be an expert. That's certainly not, I'm not an expert by any means. You know, I roll with the punches and I screw things up all the time, but that's part of being a human and that's part of being a lifelong learner, which people in healthcare are. It's also really humbling to be able to say to a patient, you know what, I didn't handle that very well. It helps them see us as human. So we know what a trauma reaction could look like, and we acknowledge it if we see it. And that can be as simple as asking if a patient needs some space or if there's something we can do to make them more comfortable. Sometimes I can see that patients are getting really, really frustrated. Everybody's coming in and asking them the same questions, and then they want them to go here, and then they want them to go there, and they have to put a gown on, and they have to leave their stuff behind. And it's a lot, right? Sometimes people just need to go for a walk, or we just need to, you know, sort of cluster our care. And that's a piece of trauma awareness. A patient is frustrated and believes that we're not giving him the right dose of his methadone. We ensure that he knows when his PRN doses are and his larger doses are given. So there's the scheduled doses and there's the PRN doses. We call the addictions medicine consult team to come and reassess the patient if the doses seem inadequate. So that could be, you know, signs of withdrawal, sweating, a runny nose, a piloerection, Those sorts of things are very obvious, and patients can tell you when they're starting to get dope sick, and it's really important that you take that seriously. And then once the doctor sees them, if they increase the dose, you go back and make sure that it's actually effective, right? This is how we build trust with people, and it's a great opportunity for collaboration too, because they can build a relationship with us, we can build a relationship with the doctor, and the patient learns that, you know, oh, okay, if I tell them I'm sick, they're going to help me. A patient says they need to leave hospital to go out and take care of some stuff at home, and we ensure that they know when their medications are due and ask if there's anything they need support with while they're out. Sometimes I give people bus tickets. Sometimes if somebody really needs to go home, and you know, there's been a lot of stuff with animals, pets lately. Like people have cats at home or dogs at home, and they don't trust anybody to go into their suite. So, you know, maybe they need to get downtown and back really quickly, and we do our best to support them. I also always check with people to see if they need harm reduction supplies on the way out the door. Anybody can hand out harm reduction supplies at St. Paul's. Doesn't matter where you are, what you're doing. If somebody asks you for harm reduction supplies, you can give them to them. We have them up on 8 Alpha, and I know Medicine has them as well. Pretty sure Emerge has them. They better. But yeah, you know, and just ask people what they need. Sometimes they just want some sterile water. And this is a huge, huge thing, because if we're not giving them sterile water, they're pulling water out of a puddle, or they're pulling water out of a toilet, or they're, you know, like it's so easy to empower people to use safely. If you're uncomfortable with harm reduction supplies, there's a lot of ways to learn about them. We have a new AMCT consult liaison nurse who's available Monday. I think they're just Monday to Friday right now, but they're here too, and they can help. So just make sure that the patient also knows what unit they're admitted on. Like sometimes people come in and they're super out of it. They don't know what's going on. And then they're like, I got to go home and get my dog, or I got to go do something. And then they come back to the hospital and they don't even know where they were. So I always make sure people know what unit they're admitted on and what the phone number is in case they need to call us. You know, shit happens, pardon my French, but sometimes people miss a bus on the way back, or, you know, things like that. And if we just say, hey, call me if you're running late, and they will do it. And it's really, really cool to see people actually know that, you know, we want them to succeed. This is a really great example of emphasis on safety, strengths-based, and skill building. Okay, this is less common, but more common. It's really funny. It kind of goes in waves, but people using at the bedside, or using in bathrooms, or using in hallways, or, you know, we'll find uncapped sharps in a used cooker at the bedside. This is a really, really important moment to talk to people about harm reduction practices. Make sure they know where the OPS is. Remind them that they can't use it at the bedside, because it's super unsafe, especially at night. You know, if they go down, there's nobody there. We're doing our safety checks however often, but if they're down and we don't know, we can't help them. So opportunity for choice, collaboration, and connection. This is happening a lot these days, where we have patients who just actually can't inject anymore, whether it's due to scarring in their vasculature, or dexterity, or vision. A lot of people that injected for many, many years are now smoking their drugs. So that's a whole different ballgame, right? Because as we know, routes of administration, dosing varies, effect varies, the length of time varies, mechanism of action, like all of it is different. So it's important that people know, A, about vein care, so rotating veins, beveling up, making sure that they really clean the site. There was a whole group of people, there's a couple of harm reduction organizations from the States that I follow on social media, and they were talking about how a whole bunch of their patients thought they were supposed to use the alcohol swab after to like stop the bleeding, but they didn't understand that they were supposed to clean the skin before and the periskin area. And as soon as they started sort of emphasizing this, infections went down. What we think is so obvious is not always obvious. So that's a strengths-based and skill building thing, because if I teach one person how to do it, they're going to teach 5 other people how to do it, or somebody else is going to see them doing it and ask why they're doing it that way, right? And people who use drugs are actually like the most educated on these things, and they are on the front line. So they're there responding to overdoses and you know, learning. We have a patient who's not coping very well with being in hospital. They are missing a lot of medications. And a lot of I get a lot of phone calls like, well, we're just going to discharge this person. And I'm like, hold on. What's going on at home for them? Do they have a sick relative? Do they have a dog? Do they have, I've had people who are in like fighting with the ministry about their children. Like they don't care that their vancomycin's due at 2 p.m. because this is much more important to them and they have to deal with it. They can't not go to court, right? So asking people how we can support them to be here for their treatment, or if we can change the timing on things, is a really easy way to deal with this. I know we had a guy who was working at the OPS once, and his shift was from 7 a.m. until 11 a.m. So we switched all of his antibiotics to be given overnight. Ta-da, no more missed doses, right? We can also talk to the pharmacist, see if we can group medications into smaller windows. Like it doesn't really matter if they miss like a calcium carbonate at 4:30 or whatever. If they're not going to eat dinner, they don't have to take their calcium carbonate before they eat, right? See if we can get things together. And then they know when they need to be present for it. And this is a really great way to look at the emphasis on safety, trustworthiness, opportunity for choice, collaboration and safety, strengths-based, and skill building. So that kind of hits all of them. I talked really fast and I talked about a lot of things, but I think my biggest message would just be that, our patients are a wealth of information and are so willing to support us in learning and are so willing to do things that we think they might not be willing to do. So it's all about building that rapport and, answering questions and acknowledging successes and sort of revamping care plans for things that aren't working, right? And people need time. So this whole idea that they're going to come into hospital and within 12 hours, they're going to trust us and they're going to get all of their meds and we're going to do their wound care and it's going to be great. And that's probably not going to happen. It might take you a few days, sometimes even more than that, of like bare minimum interaction to get people to be willing to engage. And that's okay. It's about their well-being. It's not about our satisfaction with delivering care. And I think that that's something that as an organization, we really need to remember. Hearing things like that's a waste of resources or anything like that. Like it's not. Actually, we're here to serve our community. And if that means that things are a bit slower than we think they should be, then that's how it is. It gets a lot more rewarding and, a lot easier to care for people when we actually are caring for people and not for the ideas of what we think we should be doing. So yeah, I got a really short little reference list there. And then there's a list of some books that are really good if you want to learn more about addiction. I also just finished reading Dr. Bruce Perry and Oprah did a book called What Happened to You, which has got an incredible explanation of developmental trauma, as well as sort of the feedback systems in the brain and what happens with repeated trauma, and just beautiful, very simple explanations of why things look the way they do in people who have experienced complex or developmental or intergenerational trauma. So yeah, I am around on 8 Alpha Monday to Friday, 7 to, it's supposed to be 3, but it never is. And Carlin, our educators, around, and the liaison nurses are around. And yeah, just let us know if you need help. We're always more than happy to help, particularly when it means the nurses get to learn and the patients get to stay. What's the question?
I'm going to pull up your Slido.
Oh, Slido. Uh-oh.
Just in Chrome.
Someone says they used to work with you on T10 at AGH. Good to see you.
Really? Where's the Slido?
Not T10.
There.
Okay, this is actually giving chances though for a CT scanner, scheduled antibiotics that are being missed because the patient is off unit or unwilling. Well, we end up canceling things. And usually what I do is, if it's a patient we don't know what's going on and we really need to get a CT scan or an MRI to see what's going on, I will go in and talk to them after the first missed appointment and say, hey, this is the situation. It's really, really important. Would you like me to rebook it for you? And if they say no, then we got to find some other way to figure it out, right? And there are other ways to figure it out. Sometimes we treat things with antibiotics, and if it doesn't seem to be making a difference, then we go back and we say, hey, we actually really need to do this scan. And people are generally more trusting at that point and will come around. Antibiotics, sometimes we change from, the front line or the first line treatment, we'll go down to the second line treatment. And sometimes we have to go down to the third line treatment. Sometimes we have to get them on an oral agent and move forward with it. We don't want people to develop resistance, obviously, but we also want to give people a chance to sort of get used to it. It's really different with every person. So a lot of the time we're rejigging schedules. So yeah, that's it.
Thank you.
You are welcome.